There's something just incredible about new life, isn't there? That sort of fragile wonder, taking its first shaky steps. But even in those very earliest days, challenges can pop up some common yet often misunderstood, especially for our youngest equines. So today we're doing a deep dive into colic and foals. Now, you might hear colic and think of adult horses, right?
Mhm.
But what's really fascinating here and what we want to unpack for you is just how different the whole picture is for these little ones. Our mission really is to shed light on the unique challenges, the sometimes surprising symptoms, and the critical things we need to know about abdominal pain and foals, drawing on some great expert sources. We're going to give you those key nuggets of knowledge that can turn a really complex topic into something clear, an aha moment, hopefully.
Yeah, that's a great way to frame it. Because colic in foals, it isn't just a smaller version of adult colic.
Right.
Not at all. It's fundamentally different. The causes, how it looks, eh, definitely how we have to treat it. And this unique vulnerability, it really stems from their immature gastrointestinal system, their incredibly fast growth, and just being susceptible to a whole range of specific developmental and infectious issues. So we're not just talking what colic is, but really why it's such a specific and honestly urgent concern in foals.
Okay, so let's unpack that definition a bit. Colic just means abdominal pain, right? Usually from the GI tract. But you're saying for foals, the signs aren't what you'd expect. What's the biggest takeaway there for someone watching a newborn foal?
Right. The crucial thing, and this is maybe your first key insight, is that foals rarely show those dramatic, obvious signs we see in adults. The intense pawing, looking at the flank, the violent rolling. You probably won't see that. Instead, the cues are often much, much subtler. Things like just being depressed, lethargic, maybe not nursing well. Sometimes the only sign is like dried milk on their head because they tried to nurse but didn't really latch on. Or you notice the mare's udder is really full. That subtlety makes recognizing it early really challenging, but it's absolutely vital for a good outcome. If you're only looking for adult colic signs, well, you could easily miss it in a foal.
That makes a lot of sense. Okay, so with those subtle signs on the outside, the big question is what's actually going on inside? What are these underlying causes that are so specific to foals?
Yeah, this is where we connect it back to that vulnerability we mentioned. We can sort of group the causes into a few main categories. And what's interesting is how they often relate directly to the foal's stage of development. First up, we have obstructive processes, basically blockages. These can be actual physical blockages, what we call mechanical obstructions. And the most common one by far in newborns is meconium impaction.
Ah, the first poop, right.
Exactly. That sticky tar-like first feces. It absolutely has to pass, ideally within the first 12, maybe 24 hours.
Hmm.
If it doesn't, well, it can get lodged, usually in the small colon, and that causes significant pain.
Okay, so that's number one, right after birth. What else falls under physical blockages?
Well, beyond that, you can have congenital issues, problems they're actually born with. Things like atresia ani or atresia coli. That means parts of the GI tract are actually closed off or didn't form. And genetics can play a really surprising role here, too. Conditions like lethal white foal syndrome, LWFS, it's a specific genetic thing affecting intestinal nerves, mostly seen in certain paint horse crosses like over-overo. Then there are other mechanical things like intussusception. That's where the intestine kind of telescopes in on itself.
Oh, wow.
Yeah. Or volvulus or torsion, a twisting of the gut. And hernias, where bowel can get trapped, like an umbilical hernia or an inguinal hernia down in the groin area. Colts, by the way, seem to be at higher risk for those inguinal ones.
So quite a range of physical blockages from that very first day to things they're born with. What if there isn't an actual physical blockage, though?
Right, that brings us to the next category. Functional obstructions, often just called ileus. This is where the gut just stops moving properly, but there's no physical blockage. It's often a result of something else going on systemically, like a bad infection, sepsis, or severe electrolyte problems. The gut motility just shuts down.
Okay, so the gut itself stops working.
Exactly. Then we have inflammatory processes, things like enteritis, which is inflammation of the small intestine, or colitis, inflammation of the colon. This inflammation causes fluid loss, pain, and often diarrhea. Common culprits here are bacteria, like Clostridium difficile or Salmonella, or viruses. Rotavirus is a big one, a really common cause of foal diarrhea. Parasites can also jump in early, like Strongyloids westeri, threadworms, or Parascaris aquarum, the roundworms, in slightly older young foals.
Inflammation, infections, what else?
Gastric ulceration. This is a big one and maybe sometimes overlooked. Foals are incredibly susceptible.
Why is that?
Well, stress is a major factor. Also, giving them certain medications like NSAIDs, nonsteroidal anti-inflammatories, and just the fact that their stomachs produce acid continuously, These ulcers can cause a lot of pain, and if they get bad, they can even lead to strictures like narrowings or even porphyrit, burst through the stomach wall.
That sounds serious. And you mentioned one more.
Yes, uroperitoneum. That's a ruptured bladder.
Wow, how does that happen?
It often happens because of trauma during birth, or sometimes just from the foal straining really hard, maybe with a meconium impaction. Urine leaks into the abdomen. This causes what we call a chemical peritonitis. The urine irritates everything and throws their electrolytes way off, especially high potassium, low sodium, low chloride. And again, colts seem to be at a bit higher risk for this one too.
That is a remarkably diverse list. Blockages, infections, ulcers, even a ruptured bladder. It really hammers home how unique their situation is compared to adult horses.
So given all these potential causes, does age or breed give vets any clues? Are some foals more likely to get certain things? Absolutely. The foal signalement, basically who they are, their age, breed, history, it provides critical clues. For instance, you mentioned miniature horses earlier. They actually have a higher incidence of fecaliths, these little hardened balls of manure that can cause obstructions. And age is huge. A foal that's, say, 24 to 48 hours old and colicking. Meconium impaction is way up on the list. But if you have a foal that's maybe a few weeks to a few months old showing colic signs, you start thinking more about things like intussusception or maybe an impaction from roundworms, the ascarids.
Okay, that helps narrow it down. Are there other major risk factors that make a foal more prone to colic?
Yes, a really big one is failure of passive transfer of immunity, or FTPI.
That's about getting colostrum, right? The first milk.
Exactly. If a foal doesn't get enough good quality colostrum, they don't get the mare's antibodies. This puts them at much higher risk for septicemia, a bloodstream infection. And sepsis can directly lead to that infectious enterocolitis we talked about. It can also make them more likely to retain their meconium. We also know, as I mentioned, that NSAIDs and stress are significant risk factors for gastric ulcers. And there's another condition, neonatal maladjustment syndrome, sometimes called dummy foal syndrome, which can actually cause gut injury, leading to ileus and bacteria potentially crossing from the gut into the bloodstream.
Okay, so given how fast things can go downhill with foals and how subtle the signs can be, getting a diagnosis quickly and accurately sounds incredibly important. How do vets actually figure out what's going on? What's that diagnostic journey look like?
It really is a multi-step process, and like you said, the clock is ticking. The very first thing is the age of the foal. That's just crucial for narrowing down the possibilities right away. Then vets are looking really closely at the clinical signs. Is the foal restless, pawing, swishing its tail, grinding its teeth, or is it just off, not nursing right? A thorough physical exam comes next, checking for a bloated belly, listening carefully for gut sounds or lack thereof, checking heart rate, temperature, and feeling for any hernias. And in newborns, a gentle digital rectal exam is really important to feel for retained meconium.
You mentioned something earlier about a tube.
Yes, nasogastric intubation, passing a tube through the nostril down into the stomach. This is critical. It does two key things. First, it checks for gastric reflux fluid backing up from the small intestine into the stomach. A lot of reflux is a strong sign of a small intestinal blockage. Second, it can provide immediate pain relief by removing built-up gas and fluid. Decompression, we call it.
Okay, makes sense. What about blood tests?
Blood work is essential. It gives us a picture of the whole system. We're looking for signs of dehydration, inflammation, markers of sepsis, like sometimes a really low white blood cell count, which we call leukopenia. We're also looking very closely at electrolytes, especially potassium. If the potassium is sky high, that's a huge red flag for ruptured bladder. And we'll often check IgG levels too to see if the foal got enough antibodies from colostrum, checking for that FTPI.
And imaging, I imagine that's pretty useful.
Hugely useful, especially in foals because they're small enough to get good images. Abdominal ultrasound is incredibly valuable. Vets can actually see the intestinal walls, are they thickened, suggesting inflammation like enteritis. Are the intestines dilated, meaning stretched out? How's the motility? Are things moving? Can they see loops filled with fluid? Sometimes you can even see specific problems, like the classic bullseye look of an intussusception on the screen. And ultrasound is great for checking the bladder, too.
X-rays.
Abdominal radiographs, or X-rays, are also excellent. They're really good for seeing gas patterns in the bowel, which can indicate a blockage. They can help visualize impactions, like meconium, maybe foreign material, or those congenital issues like atresia.
Wow, okay. Any other procedures?
Sometimes, yes. Abdominocentesis, which is taking a sample of fluid from the belly cavity, a belly tap. Analyzing that fluid can give clues about inflammation or infection. But vets are very careful doing this in foals because their intestines are quite delicate, friable. And if ulcers are suspected, gastroscopy, passing a camera down into the stomach, is the way to directly see and confirm them.
So it's a real detective work, using all these tools to piece together the puzzle. Once they have a diagnosis, what's the plan? Sounds like these foals need intensive care fast.
They absolutely do. It's often a race against time, and treatment really depends on what they found. We basically have two main routes, medical or surgical. For non-surgical cases, we focus on medical management. So for meconium impaction, like we talked about, that usually involves enemas, sometimes commercial phosphate ones or just warm soapy water. Sometimes oral laxatives like mineral oil through the stomach tube can help too.
Okay, what about for ulcers?
For gastric ulcers, the main treatment is omeprazole. That's kind of the gold standard for reducing stomach acid, often used with other meds like H2 blockers or sucralfate, which coats the ulcers, and feeding frequent small meals helps too.
And if it's inflammation, like enteritis?
With enteritis or colitis, aggressive IV fluids are key to combat dehydration. If we suspect or know it's bacterial, antibiotics are crucial, plus anti-inflammatories and things to protect the stomach lining. For ileus, that functional obstruction where the gut stops moving, it's mainly about fluids, keeping the stomach decompressed with a tube, and sometimes using prokinetics, which are drugs to try and stimulate gut movement. And across the board, pain management is vital. We use drugs like xylazine, butorphanol, sometimes flunixin, miglumin, but carefully. It's really important to remember that NSAIDs, like flunixin, can sometimes mask how serious things are, and they definitely increase the risk of ulcers. And some antibiotics, like aminoglycosides, are risky in dehydrated foals, and another one, enrofloxacin, just shouldn't be used in foals at all.
Got it. So lots of medical options. But what happens when surgery is the only answer?
Right, for things like a complete blockage that won't resolve, or a twist, or that ruptured bladder, surgical management is often necessary. But even before surgery, stabilizing the foal is absolutely critical, correcting dehydration, fixing electrolyte problems, addressing acid-base imbalances. That all has to happen first to give them the best chance through anesthesia and surgery. Common surgeries include an exploratory laparotomy, basically opening the abdomen to see what's going on. For stubborn meconium impactions, they might manually break it down or even surgically remove it. For twists or intussusceptions, they'll try to correct it. Or if a section of bowel is too damaged, they'll have to resect it, remove the bad part, and then sew the healthy ends back together in anastomosis, and obviously repairing a ruptured bladder.
And after surgery, it sounds like recovery is intense.
It is. Postoperative care is almost always intensive critical care, often in a specialized hospital setting. And one really significant challenge, especially in these tiny neonatal foals, is abdominal adhesion scar tissue forming between lukes of bowel after surgery. It's relatively common. So the surgeons take a lot of precautions, handling tissues very gently, using special fluids or medications during surgery, lavaging the abdomen thoroughly all to try and minimize those adhesions forming later.
That's an incredible level of specialized care. So, boiling it all down for breeders, owners, what's the most critical message about managing these newborns to prevent problems or catch them early?
Adequacy of colostrum intake is just paramount. It sounds simple, but it's the cornerstone of prevention. Getting enough good colostrum dramatically reduces the risk of sepsis, which then reduces the risk of infectious enterocolitis, and it even seems to help prevent meconium retention. So ensuring that happens in those first few hours is huge. And, for those specific genetic things like lethal white syndrome, if that's diagnosed, it's really crucial to understand the genetics. Rebreeding that same mare and stallion is strongly discouraged, and genetic testing is the way forward to prevent it happening again.
That brings us to the really big question, I guess. What's the outcome typically like? How much hope is there for these little guys when they face something so serious?
Yeah, that's obviously a key question. The prognosis for foal colic really varies a lot depending on exactly what's wrong. For the simpler cases, like straightforward meconium impaction, the prognosis is actually excellent with prompt medical treatment. We're talking 90–95% survival. Simple gastric ulcers also generally do well. It gets more guarded to fare for things like enteritis or colitis, especially if sepsis is involved. Uroperitoneum, the ruptured bladder, actually has a pretty good prognosis if they get to surgery quickly.
Okay, but what about the really serious stuff? The twists, the congenital defects?
Yeah, for those severe issues, strangulating lesions like a volvulus or intussusception, or congenital problems like atresia, or severe ulcers that have perforated the prognosis is definitely more guarded to poor. But, and this is where it gets really interesting and kind of hopeful, while we often think foal surgery is riskier than adult surgery because they're so fragile, a big recent study looked at multiple hospitals. And it suggested that for foals needing surgery for small intestinal strangulating obstructions, their short-term survival rate getting out of the hospital was actually higher than in adults. It was something like 96% survival to discharge versus 88% for adults in similar situations that recovered.
Wow, that's surprising.
It is. It really underscores that even with severe surgical conditions, prompt diagnosis and aggressive specialized surgical intervention can offer significant hope. It's not automatically a lost cause.
That's a fantastic piece of data. It really circles back to what you said earlier, early recognition and getting that foal to a specialized equine hospital quickly. That seems to be the absolute critical factor.
Exactly. That's often the single most important thing influencing the outcome. And again, prevention is key where possible. Ensuring that good colostrum intake is the #1 thing owners can focus on to reduce the risk of some of the most common and serious issues, like meconium impaction and infectious enterocolitis.
Well, we've certainly taken a deep dive today into full colic. We've explored why it's so different, the clever ways vets diagnose it, and the really intensive care these fragile patients need. It's incredibly clear that while the word colic is familiar in foals, it demands a whole different level of awareness and, frankly, urgency.
Absolutely. Understanding those subtle early signs and knowing how quickly things can change is just crucial. Knowledge is great, but it's most valuable when you understand it and can apply it. Hopefully, this discussion has given everyone listening a clearer picture of what's really at stake and also an appreciation for the incredible efforts that go into saving these young lives.
Yeah, if you zoom out, it really highlights the vulnerability of newborns, doesn't it? Across all species, really, and just how vital that specialized veterinary care is for their survival. So, what does this all mean for you listening right now? Maybe you'll look at a newborn foal with slightly different eyes, understanding a bit more about the hidden complexities they might be facing. Or perhaps you just have a newfound appreciation for the amazing science and dedication involved in helping these tiny patients pull through. What insights really stand out to you from our conversation today? Join us next time as we take another deep dive, unraveling a topic you never knew you needed to know.